Hello and welcome to our WHO Global PrEP Network webinar, Integrating STIs and PrEP for Comprehensive Client-Centered Sexual Health Services. So just some housekeeping before we start. Please type any questions or comments you have into the Q&A box, and we'll try and respond to those during the Q&A session with our panelists at the end of the webinar. And if we can, we'll also respond in the chat as those questions are happening. Please tell us who you would like to answer your questions or if it's open to anyone. Please also note that this webinar is being recorded and it will be published on the WHO Global PrEP Network website. And on this website, you can see the address just here. You can also view our previous webinars. And a final note about slides, because this is a very popular question, where we have received permission from our panelists, slides from the presentations will be distributed to attendees who have registered for this webinar. So, and please let me start. Let me introduce myself. I'm Heather Marie Schmidt. I'm the Regional Advisor for Pre-Exposure Prophylaxis with WHO and the UNAIDS Regional Office for Asia and the Pacific. And I want to welcome all of you. Good morning, good afternoon, or good evening, depending on where you are in this amazing wide world. We have a stellar list of presenters today. With presenters from Guyana, India, South Africa, the UK, and WHO. And they together will explore the importance, opportunities, we'll explore the importance, opportunities, and barriers related to integrating STIs and PrEP. You will hear clinicians, program, and community perspectives who will all bring a unique expertise and are equally important perspectives to designing and implementing available, accessible, acceptable, and integrated services for PrEP. Our first speaker is Maybe Brito de Mello, who is the Technical Officer for HIV, STI Prevention and Population with WHO Switzerland. And she will be speaking on STI integration in PrEP programs, evidence, and WHO guidance. Over to you, Maybe.
Thank you very much, Heather. And let me share my screen. And I've been given the privilege by the organizers to actually present live instead of being recorded. So I hope you can see my slides. Yep.
No.
Nope. Okay. Again. Sorry about that. This is why they record.
It's coming up now. Looks great. Thanks.
Yep. So just give me another second. Oh, now it didn't work. Just give me a second. I'm sorry about this. How is it?
Looks great.
It's just like I'm not being able to.
It was moving forward.
Yeah, now it goes. Okay, I'm really sorry. I already lost several minutes of this, so let's move on. So just a really quick recap. So we have a new estimate for 2020 for STIs. And we are talking still, as in the last update, in about one case of an STI, new case of an STI per day among adults in reproductive age, which is quite a lot, much substantial than HIV actually. So, STIs can directly affect our quality of life, particularly, of course, our sexual life, and is super stigmatized. So STIs can also cause morbidity and mortality. So for instance, WHO has estimated over 300,000 fetal and neonatal deaths each year due to syphilis, and over 200,000 cervical cancers-related cancer each year due to HPV. So in 2016, WHO has launched a global health strategy towards ending STIs by 2030, which has specific goals and targets. However, not much progress has been done so far. On the contrary, really, and here you see data from high-income countries that have a very good surveillance systems, that STIs, and here the example of syphilis and gonorrhea, are really on the increase, but particularly among MSM. So if you look at the dark green on the right and the red to the left. So we're talking about in the US, for instance, almost half of the infections of syphilis were among MSM. So, and we know that we have tools to address STIs, and the impact, if we could have effective interventions put in place, the impact would be not only in STIs per se, but in a combination of areas, as you can see here. So we understand PrEP as being a really pretty unique opportunity to manage STIs, and because it focuses on populations of high risk. So although, as you know, like PrEP doesn't really biologically decrease the risk of acquiring STIs, but the frequency of screening that's offered as part of the PrEP services can end up uncovering asymptomatic infections and facilitate access to treatment. So otherwise, those infections could go undetected, and it's basically almost over 50% of them do not show symptoms. So those who are really at substantial risk for HIV are also at high risk for STIs, and they're all candidates for PrEP. So, so in a recent systematic review that was done with populations and meta-analysis, and done with individuals that used PrEP, but also before they start PrEP. So what we see here is the purple to your right, as the prevalence among PrEP users, or future PrEP users in this case, for chlamydia and gonorrhea, it's kind of around 10%, 1 in 10, MSM infected. PrEP users is not particularly MSM, but MSM is actually a little higher. And you're heading, if you combine infection of any of those three, it goes to like 1 in 4, approximately 1 in 4 of people that are going to start PrEP that present one of those STIs. So, so the same thing for, this is the ECHO trial that shows that other populations can also be at high risk of STIs, or very high risk, particularly young girls and women in high burden countries, which are also, for whom PrEP are also recommended. And there is this not so recent model work in the US that have indicated that, frequent of screening, if they follow CDC's recommendation, the US CDC recommendation, of course, associated with effective treatment, can drastically reduce STI infections among MSM in a period of 10 years. So it's pretty impactful. So in 2017, WHO produced guidance documents for the clinical management of PrEP, and suggested that any STI infection that a person has in the prior 6 months, PrEP should be indicated, should be recommended. And also WHO suggested screening for STIs prior to PrEP initiation and at regular intervals. We currently do not have more specific guidance than this, but we're working on it, and is going to have a specific module of this PrEP toolkit that helps countries to include in the best way possible STIs as part of the PrEP services. So recently, we're actually still doing this, and so please take this as preliminary data. We're looking at countries with PrEP guidances and looking what do they have in there that mentions STI. Do they mention STIs? What do they recommend? So the top here you have, all the WHO member states, and then you have those with guidance. It doesn't mean to be specific guidance on PrEP, but at least they have mentioned PrEP somewhere. That means they have that included in their response. And you have here in red, and I must say that the left, we're talking about high-income countries, and the figure on the right are low and mid-income countries. So what we have here is that, those 26 out of the 55, which is about 57% of the high-income countries, they have some information in PrEP, and it's about 41% from low and mid-income countries. And there's a smaller amount here that's going to be a little bit more specific about STIs. So what we did find is that let's focus on countries low and mid-income, of low and mid-income. What we have here, if we look at what kind of STI management it's being recommended, this doesn't mean the practice in the country. This is what the country's guidelines or guidance documents are saying. So it's only at 3% of them recommending etiologic, like then you know which pathogen you're talking about. And almost around 40% are recommend syndromic approach. That means only when a person shows with a syndrome, with a symptom on STI, that they're going to be managed. And you have a portion of countries that says both, but like a third does not give any specific details about STIs. And of course, the scenario is very different for high-income countries. So, and then for those countries that did specify, they had more information about specific pathogens. So we look at that, and we have the blue, the high-income countries, and the purple, low and mid-income countries. What you have is like a pretty universal screening for syphilis and HPV. And HPV is a lot to do with, looking at liver functioning. So it's kind of back of the package. But then when we look at screening for gonorrhea and chlamydia, is the NGCT, the purple bars are really low. It's like half of them they're recommending. And this is mostly likely due to the price to test for those two infections. But one thing that called my attention when I was analyzing this data is that the really lack of integration in both high and low income countries of vaccination into the program. So here you have, although let's say HPV vaccines are very cheap, you still have a third of the countries that do not say anything about vaccination in their PrEP guidelines. But today we do have several tools to support the inclusion of STIs, regular screening among PrEP users. So for example, we have rapid screening and diagnostic tests for syphilis, including the pretty affordable combo for HIV and syphilis screening. We have rapid diagnostic tests for syphilis, not just the screening part. We have point-of-care platforms that can be used for several infections, which include STIs, are the same they're used for TB, for HIV. But as I mentioned before, unfortunately, molecular testing are pretty expensive still, and they are required for the diagnostics of gonorrhea and chlamydia. We hope that with increased demand by countries, if they do adopt those strategies, of testing within their PrEP programs, that prices will come down with greater demand. So meanwhile, there are some possible alternatives, and one WHO is working right now. That's a potential recommendation of you actually pulling together samples from 3 anatomic sites or several anatomic sites into just one single test, which basically drops your cost by a third. And there's also specific recommendations from WHO on self collection of samples, which can be used specifically for gonorrhea and chlamydia. So there's also really effective demonstrated countries have experience on HIV interventions that there's no reason why they shouldn't be applied to STIs. So for instance, if you're talking about partner services or if you're talking about social network-based testing, is the same thing. I mean, if you have someone positive for syphilis, why shouldn't you go after their sexual partners and try to engage them? Same way if you use their social and sexual network. So that brings a lot of yield to HIV, and the same way it should bring for syphilis. And the structure is there. It's just a matter of basically getting organized and starting. The other approach, for instance, is when you start really thinking about, doing a person-centered approach where you no longer are talking about HIV programs, STI programs, but you can do something more integrated, focus on sexual reproductive health, where people come in. If they need PrEP, they have PrEP. If they, for instance, already have HIV, they can, be treated for HIV, and regularly all of those will be screened for STIs. This is actually I picked one example. It's just one example. There are more. That's called the status neutral model by New York City. So WHO actually suggested opportunities for countries to try to optimize STI prevention control for PrEP users. And here is a list. I'm just going to highlight some. So, of course, countries, and we've seen how many, could update their guidelines and give a little bit more specificity to it to guide those who are dealing with, the clients, that how they should approach STIs. And syndromic approach is super important, but for this particular population that's high risk, we should really be moving towards knowing which STIs, affecting the person, and those which do not present any symptoms. So that is the population to start moving from syndromic approach to diagnostic testing. So of course, when you do that, you need training. One thing that's for, and we do this, we say this for every HIV service, you need community support. So raising the awareness of HIV community for STI is going to be, it's super key. And then the use of those new resources in terms of laboratory or models of care. So with that, I end my presentation. I thank my colleagues who worked on this in different parts of the presentation. And I want to remind you that really when you're talking STIs, that there's an enormous amount of people affected that they just don't know, particularly women. So with that, I end and hand it back to Heather. Thank you.
Thank you, Maybe. We are now moving on to our next speaker, and hopefully my screen is sharing properly. And our next speaker is Diarmuid Nugent, who is a consultant in HIV medicine and sexual health at 56 Dean Street, Chelsea and Westminster Hospitals, NHS Trust in the UK. And he will be presenting our first case study entitled Our PrEP Journey at 56 Dean Street.
Hello, my name is Diarmuid Nugent. I'm a doctor in HIV medicine and sexual health based at 50 Dean Street. We're a sexual health service in central London, and I'm very pleased for the opportunity to share with you today our journey to PrEP provision at Dean Street. A bit of background first about PrEP in the UK. So although PrEP was first approved in the USA in 2012, its popularity in the UK really began to take off after publication of the PROUD study results showing a dramatic reduction in new HIV infections amongst gay and bisexual men at high risk of HIV acquisition. It wasn't until October 2017 where we had the PrEP Impact Study, a large-scale demonstration project which allowed us to offer PrEP for free to individuals identified via sexual health clinics to be at high risk of HIV. However, numbers on the study were capped and recruitment frequently filled up after places became available. So finally, in August of last year, we were able to offer NHS PrEP for free to anybody who we identified to benefit from it. And as it stands, PrEP via the NHS in the UK can only be offered, prescribed and dispensed via sexual health services. In terms of how we've interfaced with that at Dean Street, well, we had a private PrEP service in 2015, but it was small, particularly because we were restricted at that time to offering branded Truvada, which was prohibitively expensive for most people who needed it. There was very much a grassroots community movement to encourage individuals to be able to self-source generic PrEP online through websites such as I Want PrEP Now. And we supported people self-sourcing PrEP from 2016 through clinical advice and blood monitoring for them. We formalized this arrangement in 2018 with something called PrEP Shop, where we actually purchased the generic PrEP online ourselves and then sold it on at cost price, not for profit, to individuals who wish to have it. And with the arrival of free NHS PrEP, we were able to wind down PrEP Shop last year. So the number of individuals accessing PrEP from our service has steadily increased over the last 4 to 5 years, and we hit an important milestone in July of this year where we recorded 20,000 current PrEP users. So that's 20,000 people currently accessing PrEP and PrEP-related care from our service, and we were very proud of that achievement. Having that number of individuals accessing PrEP means that you have to have really robust and efficient processes on the ground to be able to cope with that level of demand. And to put it into context, if 20,000 people attend for PrEP, even if each one only attends once every 6 months, that still equates to over 700 attendances per week and over 100 attendances per day. So we really need to ensure that there are efficient mechanisms on the ground to be able to cope with that. An important one of those is for nurse-led PrEP provision, and that means that all of our nursing staff are trained to identify those who would benefit from PrEP and to dispense and prescribe PrEP to those who need it. In addition, they're able to identify those with more complex medical issues that require more senior medical involvement and medical support. Being a sexual health service also means that sexual history taking is integral to what we do. Those who receive PrEP from us don't all walk in asking for it. People may come to us for other reasons, be it for a sexual health checkup, for assessment of genital symptoms, for treatment of a diagnosed STI, or for provision of emergency post-exposure prophylaxis for HIV. And in all of those circumstances, we're asking questions about how often they have sex, who with, and what kind of sex they're having. And all of our staff are well trained to identify from that information those individuals who would benefit from PrEP. We then have an on-site pharmacy and medication available so that PrEP can be provided in those circumstances right away if needed. In addition, we have an online tool which encourages people to think about their own risk for HIV, and it asks a few basic questions about sexual behavior and about gender identity, and from that advises whether you're likely to benefit from PrEP, and it links in with further information then about PrEP and to booking an appointment if need be, and this can be accessed by anybody through our website. So being an HIV care centre as well as a sexual health service means that we're in a good position to learn lessons from those individuals who are newly diagnosed with HIV. And although we've seen a really dramatic reduction in new HIV infections particularly amongst gay and bisexual men over the last 5 or 6 years, those benefits haven't been equally felt by everybody, and in particular we've not seen the same dramatic falls amongst the youngest gay and bisexual men, so those aged 21 and under. And that finding has motivated us to ensure that this group are prioritised for walk-in access to all of our clinical services. Prior to the introduction of NHS PrEP, we also had something called Generation Zero PrEP, and this was funded through charitable donations, whereby we were able to provide free generic PrEP to the youngest gay and bisexual men accessing our clinic services who couldn't otherwise afford it. From February 2019 to May 2020, we had just over 200 newly diagnosed cases of HIV. And when we look back at those cases, we see that around 1 in 3 have attended our service before. Around 88% of those were aware of PrEP, but only 34% took PrEP when offered. So clearly awareness of PrEP is high, but uptake is much lower. In addition, we identified a number of risk factors which are predictive of future HIV acquisition. They include having a rectal STI, so chlamydia or gonorrhea, a new syphilis infection, drug use in a sexualized context, so chemsex, or presentations for emergency post-exposure prophylaxis for potential HIV exposure. And we found at least one of those risk factors was present in around 85% of our newly diagnosed cases. And that's led us to offer something called opt-out PrEP. So that means that anybody coming to clinic for one of those reasons will automatically be assumed to benefit from PrEP and will be offered it and provided with PrEP unless they specifically would prefer not to receive PrEP and want to opt out. So it's not enough just to identify and provide PrEP to those who need it. We also have to support those who are taking PrEP, and particularly during the COVID-related restrictions in the UK, we've seen some changes in sexual behaviour at times, and perhaps some people having less sex for a period of time, and therefore we wanted to make sure that people were provided with the best advice about how to safely restart PrEP. So in those whose HIV risk comes from anal sex, we've merged the daily and event-based dosing advice into something called Quick Start, which is this idea that you can restart PrEP with a double dose, which gives you rapid protection after just 2 hours, and then just stay on daily thereafter while you remain sexually active, giving you continuous protection. The images on the right are just from the leaflets that we provide about this, and we've backed this up with some video and web-based advice as well. We've provided little key rings, which are pill holders, which can hold at least 2 PrEP pills so that individuals can have their PrEP with them and start if they need rapid protection, and will be protected after 2 hours. We've also moved to 6-month prescribing, and this means that there's a less of a chance of individuals, running out of PrEP and having to stop if they maybe have difficulty making an appointment. So it reduces the chance of that. Having said that, clinical guidance in the UK is still that 3-monthly HIV testing is what's recommended, and this is facilitated through ordering an online HIV test kit if that's what you'd like. For those who are really struggling with tablets and with tablet fatigue, our health advisor team have created a specific support and counselling group in order to help with this, providing advice and support for those having these difficulties. So although a third of our newly diagnosed HIV infections were from individuals who'd previously been to Dean Street, that means 2/3 had never been to our service. So it's really important that our messages about HIV prevention go beyond those who are just already attending our service. And broadening engagement is essential. So like many of you, we have done outreach work to sex on premises venues, and just before the COVID pandemic, we started a service whereby PrEP could be provided on site to individuals attending a sex on premises venue. And our experience of that was that these were often individuals who were not accessing mainstream sexual health services, but who nonetheless had a significantly elevated risk of HIV acquisition. We're lucky at Dean Street to have really strong community relationships, and we have had a clinic for trans and non-binary people, which has run for many years. And through that, we're able to identify the need for PrEP and to provide clinical support for it. We've had great support, particularly online, from sex workers and from adult industry performers who have been really key to promoting pre-exposure prophylaxis to their often large online followings. And also local hospitality venues who've been able to help us to support us by showing promotional material, etc. About PrEP. We've developed many of our web-based resources in such a way as to ensure visibility of those groups that we feel should be prioritized in our particular risk of HIV, and they include ethnic minorities, trans people, and young people who we want to make sure are well represented in those resources. We have a large amount of output from our various social media platforms, and in our campaigns around PrEP, influencers on social media have been important to help amplify our messages also. But nonetheless, we're very aware of the digital divide, and to make sure that individuals who are at risk of HIV who may not have access to that kind of technology are also nonetheless able to access our service and receive the information and support that they need. So I think that's something that we need to remain very conscious of, particularly in the COVID area where many face-to-face services have been restricted. This is an example of some of our materials. So on the left is a shot of our website talking about PrEP, and that would link into further clinical advice and then to being able to book an appointment. The center is an image from the PrEP for Summer campaign, and on the right is a COVID vaccine drop-in vaccination event held at a gay nightclub in London, and we coupled up there by offering PrEP provision at the same venue at the same event, so that individuals could come and get protection from COVID and from HIV all in one. So in terms of future challenges, well, we're still seeing around 10 cases of newly diagnosed HIV per month at Dean Street, and we're really keen to understand why some individuals are still slipping through the net of combination HIV prevention. I feel there's probably some important qualitative work to understand the subtleties of the dynamics of that HIV transmission and to understanding how better we can help. There's likely to be a much broader choice of antiretroviral agents available for PrEP, as well as different mechanisms of delivery, such as injectables and implants. And I think that it will be a challenge for us as to how to operationalize that in practice. With such a large cohort of PrEP users, we see greater and greater degrees of medical complexity. So some individuals accessing PrEP are much older, have other medical comorbidities or take other medications which may be nephrotoxic. And it's important to look at, to be able to identify those individuals and to be able to provide them with appropriate medical support. Finally, I'm aware this is a global audience, and I hope that there is something that you can take from the talk which will be applicable to your context, and likewise, I hope to learn from all of you. But I wanted to just bring up that one of my colleagues, Dr. Kirti Gedela, has been working on a project in Indonesia looking at HIV prevention amongst gay and bisexual men at risk of HIV there, using some of the tools from Dean Street, and it's been an important partnership for us, albeit with significant political and social obstacles on the ground, but nonetheless an important and valuable partnership. And I'm just going to end with the image of our front door of our clinic, where we've really put the message very prominently that PrEP protects from HIV, just to make sure that everybody gets that message when they come to our clinic. I'm very happy to take any questions. Thank you.
Thank you, Diarmuid. And we now have, and we will be taking questions at the end of all of the presentations. So please, I know that people are already putting them into the Q&A chat. Diarmuid will be answering some of those questions already, and we'll have a very robust discussion at the end. Our next case study is from Guyana, and we have Tariq Jagnoring, who is the Program Manager for the National AIDS Program Secretariat, Ministry of Health in Guyana, and he will be speaking about PrEP and NPEP in Guyana.
Hi, I am Tariq Jagnoring, Program Manager of the National AIDS Program, Guyana. It is my objective today to give an outline of the implementation process of PrEP and NPEP, along with highlights and some of the lessons learned, challenges, and outcomes. Before I do, allow me to give you a brief overview of the HIV situation in Guyana. In terms of the UN AIDS targets, in 2020, we would have achieved 94% of persons living with HIV who know their status. 70% were placed and retained on treatment, and 87% achieved viral suppression. In terms of the key population prevalence, transgender people stood at 8.4%, female sex workers 5.5%, men who have sex with men 4.9%. PrEP was started in Guyana in 2019 on a small scale through a public-private partnership with a main streamline towards PrEP being offered by private clinics who focus on discordant couples, mainly with extension to key population. 5 private sites were used. The initiative came to a pause the very year. The general opinion among the key population is for a preference of having PrEP in public settings where the care and medication provided is free. It was observed that the preferential approach for PrEP, in keeping with reports from Jamaica by key population, that 71.8% of MSM preferred accessing PrEP from a non-HIV site, while 40.7% preferred accessing PrEP from a CSO site. This points to the need for PrEP to be offered at public facilities. There's a long history of working with civil society organizations with anecdotal evidence of the need for PrEP by those said CSOs and key population. Added to the strong political support was also offered on the expansion of PrEP, with also support from private sector. From evidence coming out of the 2017 Behavioral Biological Surveillance Survey, there was an urgent need for PrEP, especially for key population. Hence, the openness for expansion and readily execution of PrEP in the public clinic became a priority, receiving support from civil society organizations, NGOs, political arena, and private sector. With the launch of the newly developed National Strategic Plan, HIV Vision 2025, PrEP became a priority as part of the combination HIV prevention strategy, offered principally to key population, including MSM, female sex workers, transgender people, migrants, serodiscordant couples, drug users, among others. In the 2017 BBSS, the key population acceptability was very low compared to 2021. This had a lot to do in terms of the cost for PrEP, the use of public and private sites to offer PrEP, as well as the availability of PrEP to serodiscordant couples rather than key population. However, in 2021, after indicating that PrEP would be free and at public facilities for key population and serodiscordant couples, the acceptability rate drastically increased, where MSM indicated that 83% would accept PrEP, female sex workers at 88%, and transgender women at 85%. For the expansion of PrEP services, several groundworks were put into place, inclusive of the revision of medical resources, which included medical supplies, drugs, human resources, which assisted with the expansion of PrEP services in Guyana. Selection of sites were done based on the CDC and WHO eligibility criteria. National adaptation of the PrEP and NPEP guidelines was done based on the WHO guidelines with technical guidance from PAHO. Incorporation of best practices of regional use of PrEP was included from regions such as Barbados and Bahamas. While expanding PrEP, there was incorporation of the STI, hepatitis B and C. Adaptation of the WHO monitoring tools for HIV, STI, and hepatitis in key population was done, while there was strengthening monitoring for PrEP and NPEP by the surveillance team, with a monitoring plan and indicators was outlined. Inclusion of STI in the PrEP rollout was well facilitated due to the already pre-existing point-of-care testing for syphilis that was offered by care and treatment sites, CSOs, and private facilities. Additionally, training of all staff at the site selected to deliver PrEP and NPEP with the help of PAHO and PANCAP was done. Development and distribution of intake forms, screening forms, algorithms, follow-up forms, and PrEP registered, along with monitoring tools, was facilitated. Developing a costing for PrEP delivery for the next 5 years is in progress. Strategic planning to combine PrEP, HIV self-testing, STI screen, and linkage to treatment was initiated. HIV and STI monitoring prevention for all at-risk clients for seroconversion was done. The outcomes. The recent scale-up of a structured and comprehensive PrEP program was facilitated with a good response thus far, with the uptake and involvement from key population and CSOs, including private sectors, well appreciated. There was a strengthening between the public and private partnership. Key populations are now provided with extensive options to access HIV and STI services. Trained healthcare workers are available to provide PrEP, not only in the public sector, but including the private healthcare workers with the guidance from PAHO and PANCAP. Repurposing of the WHO PrEP guidelines to the local setting for PrEP, HIV, STI, and hepatitis delivery. There is the best practice experience from Barbados and Bahamas was able to be applied locally to the Guyana setting for a successful outcome. CSOs and NGOs involvement in PrEP campaign, expansion and implementation, which is now a priority area being offered under social contracting by the Ministry of Health. Seronegative clubs offered PrEP to their clients. Key population involvement and orientation to bring clients to care and treatment sites using a card system. Extended hour clinics also offered PrEP to clients' partners that are HIV negative. Some of the lessons learned shows that there is a great demand and support for PrEP by key population, civil society organization, and private sector. There is a need and importance for collaboration not only with ministerial agencies, but also private sector, local governmental and non-governmental agencies, and the need for regional collaboration, such as was done with Barbados and Bahamas. Also, there was the cost-saving initiative and practice of adapting and repurposing already pre-existing resources for local use, which benefited Guyana extensively. Continuous dialogue with the community is needed to understand their needs, such as PrEP on demand. Innovation of services which have led to adaptation of differentiated services to target key population. There is also the importance of already having pre-existing point-of-care testing for HIV, STI, and hepatitis with timely results and linkage to care. There were some challenges faced while rolling out PrEP, including the coordinated structure not only between the public and private sector, but also with CSOs and key population. Stigma and discrimination continue to be an issue, not only resulting in gender-based violence, but also death. There was a high loss to follow-up with somewhat difficulty in tracking and providing treatment. Lack of local expert resources on the ground to provide PrEP resources and additional advancement. There's a high cost of programming peculiar to Guyana's geography in terms of the interland areas, especially when it comes to integrating STI testing for PrEP within the interland area. A weak paper-based system continued to exist with challenging for data analysis and monitoring at the national level. Ongoing monitoring of ARVs and med supplies continue to affect treatment. COVID-19 impact on finances and PrEP continue to be a problem. And the STIs on the increase, especially when it relates to syphilis. The way forward with PrEP in Guyana. It is our goal to develop a costing for PrEP, HIV, STI at the public facilities, so it can be better expanded in other areas regionally. HIV self-testing feasibility rollout integrated with PrEP and condom use is one of the biggest, also included as one of a major area for the remaining of the year. Robust monitoring of PrEP services to facilitate further expansion and integration to other sites. A study is needed to focus on the impact of PrEP on key population and general population, as well as a more involvement between KPs, CSOs, and the private sector. Thank you. I do welcome any questions and comments.
Thank you, Tariq, for that excellent overview of what is happening in Guyana. Our next speaker is Saika Malik, who is the Director of the Implementation Science at the Wits Reproductive Health and HIV Institute in South Africa, and she'll be presenting our third case study on integration of STI management into PrEP programs, a South African experience. Over to you, Saika.
Good afternoon. My name is Saika Malik. I am the Director for Implementation Science at Wits RHI, based in Johannesburg. I'd like to thank the WHO for the opportunity to share some findings from our experience of integrating STI management into PrEP programs for adolescent girls and young women. South Africa has the highest number of new HIV infections, with the highest rates amongst adolescent girls and young women aged 15 to 24, amongst whom HIV incidence is 3 times higher than male peers. South Africa also has some of the highest rates of STIs in the world, high rates of asymptomatic infections, particularly amongst women, and rates in adolescent girls and young women almost double those of older women. High rates of both prevalent and incident infections have also been seen in a number of PrEP trials, and there's growing evidence that STIs may be a predictor of HIV acquisition. Added to these high rates of HIV and STIs, adolescents and youth often lack knowledge about STIs and their potential consequences. This data supports integration of PrEP and STI services in South Africa. South Africa was one of the first countries to roll out daily oral PrEP for people at high risk of infection. At the end of June 2021, just under 300,000 beneficiaries had been reached with PrEP through 1,907 implementing facilities. 150,000 of those initiations have occurred in the last financial year. The graph on the right shows the growth in the number of PrEP beneficiaries since introduction. The current national PrEP guidelines stress that STI screening is part of the PrEP service package, with most facilities providing symptom screening for STIs. The national STI guidelines also recommend provision of integrated services with linkage to PrEP services for HIV negative individuals who might be at high risk. These guidelines also allow for a diagnostic approach to STIs for adolescent girls and young women and PrEP users where possible, but implementation is limited. This slide provides an overview of the predominant existing national model for integrated PrEP and STI services across the cascade of services from information provision and linkage to PrEP services to the provision of screening for STIs and other services. STI management, which has been primarily syndromic, and partner notification and treatment. The slide shows that although information and linkage happens in multiple spaces, including online, community, and facilities, the rest of the cascade of care is primarily delivered through a facility-based model. The third row highlights the package of services, which predominantly consists of syndromic management, and the final row highlighting the health worker cadres involved in delivery. However, this approach had a number of challenges, and this slide highlights some of the main challenges across the care continuum. Client information and available IEC materials on STIs were limited, and existing materials focused mainly on HIV and PrEP. Screening for symptoms identified some people with STIs. However, the use of diagnostic screening was limited, and even in some sites with gene expert machines, waiting times were considerable. The reliance on syndromic management was likely to miss many, particularly women who are often asymptomatic and potentially overtreat vaginal discharge syndromes, some of which are not due to an STI. Partner notification and treatment were also challenging, and even where diagnostic approaches were being implemented, there were delays with laboratory test results and inconsistent return for treatment. Project PrEP is a Unitaid-funded project implemented in 8 fixed and 4 mobile facilities in 4 high-priority clusters in 3 provinces in South Africa. The service delivery model includes strong demand creation interventions through online and community platforms. The fixed facilities provide an anchor for services with a roving mobile unit extending the reach of services in the surrounding catchment of the 2 fixed facilities. The interventions are delivered by nurses, counsellors and peer educators in line with national guidelines. The project also implements and evaluates service delivery adaptations and innovations, including a number of sub-studies. The project began implementing services in December 2018, and to date, approximately 18,000 individuals have been initiated on PrEP, with over 11,000 being adolescent girls and young women. One of the objectives of the service delivery model for Project PrEP was to strengthen STI integration within PrEP services, and the project sought to strengthen the existing model by adding activities and innovations highlighted in blue. These included intensified community campaigns, outreach through community-based organizations, and the development of a number of digital tools for the National Department of Health, including a chatbot, various social media platforms, a website with a clinic finder function. STI information and linkage were integrated into these platforms. Screening for STIs was conducted at both health facilities and communities through mobile clinics, with capacitation of health workers and enhanced monitoring of STI screening and management. STI samples were collected from PrEP users on site and sent off-site to laboratories for testing, with clinician contact for results and return to the clinic if treatment was required. Repeat tests were done at 7 months and 12 months to coincide with PrEP continuation visits. Partner notification and treatment was also conducted through mobile and fixed facilities. However, this remains challenging, and we're currently looking to adapt these further based on new evidence, which I'll share. So what have we learned from our sites? We've learned that routine symptom screening is feasible and can identify symptomatic STIs. This slide draws on routine M&E data and shows that of the over 20,000 clients, of whom the majority were provided PrEP services, 90% were screened for STIs at first visit to the clinic. The baseline prevalence of an STI symptom was 9%, but varied with age and gender, with the highest prevalence of symptoms amongst 21 to 24-year-olds. So symptom screening works to identify some STIs. Through our expanded social media platforms, we've learned that young people want information, and we are seeing a lot of engagement on our social media platforms. Here you can see some of the questions posed to Sister Unati, our chatbot, social media and WhatsApp groups. These include requests for information on symptoms, how to get tested, and what to expect at a health facility. For example, will I just get STI treatment, or will they first check if I have an STI or not? Social media platforms have reached approximately 30 million beneficiaries over the last 6 months, with 2.5 million engagements with beneficiaries. Young people want trusted information, and digital media has the potential to reach, engage, and link young people to services. At the project sites, we implemented diagnostic testing, with samples being taken at facilities by a provider and transported off-site. We confirmed that there was high prevalence of any curable STI amongst male and female PrEP users enrolled in our STI sub-study, with 34% positive. In women, this was about 33% and 39% amongst men. Prevalence of STIs amongst females by age showed the highest rates among those under 20 years, with an overall prevalence of a curable STI at 45% in this age group. Having implemented a strengthened diagnostic approach at these sites was not without challenges. The model requires availability of a laboratory with capacity to process specimens. The use of a lab requires transport of specimens, and there are challenges with leakage as well as the availability and cost of transport. Lab tests are costly. Results are not available immediately, and clients are required to return to the clinic for treatment. Mobile clinics also have challenges with space for specimen collection. Consultations become longer, and clients are not always willing to wait for specimens to be collected. Availability of correct drugs for STI treatment remains a challenge, as does partner notification and return for treatment. We know from our online platforms that many young people are reaching out with questions about STIs, but what do young people have to say about when, where, and what they prefer with regard to service delivery for STIs? With funding from the National Institutes for Health Research in the UK and in collaboration with the Brighton and Sussex Medical School, we conducted a discrete choice experiment to see what preferences for service delivery were amongst youth. We interviewed 493 participants, the majority of whom were female. We found that there was a preference for self-sampling, for short waiting times with receipt of results preferred within 2 hours. STI result notification via SMS or online platform was preferred, as was access to treatment through pharmacies and consultation through telemedicine. For partner notification, expedited partner treatment was preferred over notification slips or providers reaching out to contacts. In conclusion, we have a number of recommendations. Continue to leverage and expand online platforms to improve access to information and to engage and link young people to care. We need to continue to improve and expand our models of integrated STI and PrEP service delivery bidirectionally. We need to reach young people at places of convenience outside of traditional healthcare settings and reduce the cost of diagnostic screening and management approaches. We need to think about how to simplify STI management alongside HIV prevention. We need to also think about simplifying treatment and partner notification and treatment models. We need to improve monitoring of all aspects of HIV prevention, including STI management, at both the program and individual level. And we need to demonstrate and build the evidence base for the use of point-of-care testing and self-care model. We have the potential to extend and evaluate existing adaptations and models of care to more community-centered models and step care models. In conclusion, I would like to acknowledge my colleagues at VETS-RHI, the National Department of Health, the University of Brighton and Sussex, our project teams and beneficiaries, our youth advisors, and our healthcare providers. Thank you.
Thank you, Saika. And we have our final case study for this this evening or this afternoon, depending on where you are in this world, from Deepika, who is a sex worker and member of Ashadaya Samiti in India. And she'll be presenting community perspectives on PrEP and STIs. Over to you, Deepika.
Hello, Namaskar. I am Deepika, a sex worker at Mysore in South India. I am a member of Ashadaya Samiti, a sex worker organization. I can speak broken English, so I have written down what I would like to say. I have been asked my friends present today as most of us don't know in English. I volunteer my time with the organization and we have been PrEP. Advocate from all time. We started the PrEP demonstration project more than 6 years ago. So Ashadaya has been running several health and development programs, including HIV, SRX, social entitlements, etc. For me, male, female, transgender sex worker. In 5 districts of Karnataka, we are covered almost 8,000 sex worker. All projects are run by us. From 2013, we started learning about PrEP from our advisor Sex work operation was fast changing than in Mysore. From street-based repose become more than hidden and home-based. Many new sex workers were facing a challenges in using condoms. We started providing information on PrEP during the outreach, one-to-one and group meeting. Many community members started asking for PrEP. We needed to find out if there was a community interested. Challenges, what is there? Preference on the distribution, clinical service, etc. PrEP was introduced only after we were sure that many people would take it. So, lot of efforts was put in the providing education and preparedness. Today in our community, most of the sex workers have full knowledge on PrEP. They understood its importance of PrEP. It protects only from HIV and not from STI or pregnancy. So we need to use both PrEP and condoms. PrEP is very important in our lives. It has a major role when it comes to our boyfriend, husband, regular partner, or clients when condom use is compromised. Initially, we were worried many girls may stop using condom. But over the last 15 years, we had adopted a no condoms, no sex policy. We have brought down HIV significantly. There is a high level community norm not take the clients without condoms. During the demonstration project, the norm was about using condom and PrEP. During the demonstration project, it was very clear that condom use did not get compromised. All participants had high awareness to condom use as well as to PrEP. If condoms were not used, PrEP will not protect our community against STI. We had regular medical checkup up for every sex worker for 4 times a year. This was to screen for STI and SRH services. So it was easy for PrEP user to come to the clinic every 3 months. All these services were provided to the PrEP. User also, we have our doctors, community counselors, and community nurses who were trained by the doctors. Our team use a microplan so that no one left behind. The check on condom use, mobilize for the clinic visit. Check on any symptoms of STI or other problems. Follow for PrEP, adherence, HIV test, etc. As a community, we know HIV and STI are critical work hazard. So we need to take care of our health. Through personally